us for improving critical thinking and clinical reasoning for new behavior analyst methods for promoting reasoning skills during student supervision. It's a really long title. And I was just telling the live group here that this is the first time that I've done people on the web and people in person. So bear with me as I figure this all out. I do want this to be interactive. So if you're online, you can use the chat, and I'm actively monitoring the chat. And then if you're here, just feel free to like yell it out, say something. All right, let's get started. So our training objectives for today, I'm looking to define clinical reasoning, which I'll explain why I picked this topic in more detail, give some examples of clinical reasoning in other medical fields, identify examples of critical thinking skills in the field of ABA, and then finally ending with listing out some strategies for teaching clinical reasoning to students. So disclaimer here, I am definitely not an expert on this topic at all. And this is an introduction to the topic. And I'll give you a little info on why I chose it. I teach at Simmons University, and I had the opportunity to go to a medical educational field, little presentation on clinical reasoning skills and context. And it blew my mind a little bit. So I have decided to just kind of dive right into this topic. And I hope that everyone gets as excited about it as I do, but I'm definitely by no means an expert on this at all. And a little bit about Bierman. So I know the people here kind of probably know who we are a little bit, but for those of you joining online, we're founded in 2006. Right now we're in 7 states. I'm currently sitting in the state of Arizona, in which we open our Tempe office on Monday, which is really exciting. We are precision teachers, so I'm going to drop a few precision teaching things in here just because I felt like it. And myself, I'm the chief clinical officer here at Bierman. I also teach at Simmons on the side. And I'm excited to talk about this topic. A little background from the audience will be very helpful for us as we go through this. So you can either use your phone, forgot to mention, you'll need your phone. Use your phone to join via the QR code here, and then I'll have a website up in a second that you can see. And we're gonna ask some questions of the audience. Is the QR code working? We'll find out. Okay. Did it take you to Mentimeter? Great. I'm gonna end the show so you can see the actual thing.
I know, it's so fun.
All right, so on here, we're gauging our audience, seeing how long have you been a BCBA? Shay, did you answer the not yet?
Mm-hmm.
You're ahead of the game by being here. Okay, so we have a pretty big mix here, 3 to 4 years, 5+ years. Those of us who are very old, 10+ years, 1 to 2 years. And then not used to doing this on the second screen. Really testing my technology ability today. All right, do you provide supervision currently?
Please say yes, since it restarts on first.
I think you can say yes. I think you're good. All right, so we have a mix. And think back to your time in supervision. Do you know how long your supervisor was a BCBA? There's some serious thinking faces going on here. And we have some in the chat, 1 year, 1 to 3 years. Okay. And my last question.
3 to 5 years.
How confident are you in your supervision skills? I'm very curious. It's anonymous, by the way. So if you really think you're the world's best supervisor, feel free. I actually appreciate the fact that no one has answered that they're the world's best supervisor. All right. So we will get back, hopefully, to our presentation. Okay.
Is this a different one?
No, this is the same one. So we're moving on from that. And part of the reason I asked the questions about how long, was your supervisor in the field and how long have you been in the field and how confident are you in your skills is that our field has obviously changed quite a bit over the years. So I think, my supervisors were in the field for a very long, very, very long time. And I feel very fortunate about that. But as the field has grown so much over time, and you can see like the huge steep slope here, obviously the amount of expertise that people get in supervision goes down over time. And I think we're such a baby in the field still that we haven't quite figured out what supervision should look like as a uniform way across the board. In addition to that, if you look here, 72% of the field is practicing in autism. And then autism, as we know, most of our funding is coming from medical insurance, which is lumping us into the medical field. So why clinical reasoning? Why did I get super excited when I went to a medical presentation? The term actually has a long history in the medical field when used in the academic setting. So what I had learned is that most fields in the medical setting all use the term clinical reasoning when they're teaching their students, both in academia and then out in their like field work or practicum, or I don't even know what medical doctors do. Residency, that's it, the word, yes. So they use clinical reasoning as a uniform term, and there's lots of research out there on it. There's a wide variation in its use, however, so there's actually a ton of research out there that people have published on how they use the term differently, but overall, it is in clinical training in the medical field. And one uniform term to look at it is referring to a practitioner's ability to observe, analyze, and make the appropriate clinical decision. So I think that like very much so applies to what we do. When I did go to this presentation, the professor happened to be in the athletic training field, and he had published in clinical reasoning research. And he was like so upset when he saw this article published because athletic trainers aren't on there. And I was like, dude, I feel you. Like, I'm really mad too that we're not on there, because if you look, there's occupational therapy, speech and language pathology, clinical psychology, other non-medical psychology fields. So they all closely tie into our field of behavior analysis. So just like him, like we're left out in more like widely reached research. So I feel left out. And a lot of it is in the research in terms of undergraduate training, postgraduate training, practicing health professionals. So I think we have a lot of room to grow in this area. And someone in the chat said, yes, we need our name on there. We do. And I think too, the medical profession has been around for a very long time, much longer than us behavior analysts. So we really should be using some of their resources sometimes and looking at medical professionals, what they've done. They've clearly done a very good job at uniformly training people in their field. So why not us kind of look to them for some guidance? And I think, why do we need to think about clinical reasoning a little bit more as supervisors in the field of ABA? There's, I think personally, I have a lot of feelings about cookie cutter ABA and places that I think our field are going a little bit. And we really need to be better at teaching people not just cookie cutter ABA. You can't always click a button and come up with the correct treatment option and have it be like the right one. We have to teach the analytic skills that they need. I heard people say like, put the analysis back in behavior analysis. Like we really should be thinking that. And we also, need to think about the families that we work with and individualized treatment. So if we don't, what does this look like for us as a field in the future if we're not thinking about teaching people analytic skills? And how does this make families feel? Like, do families want to come in and say, like, oh, my BCBA was trained that you enter in all this data and it tells you what the program is, and they're just going to give me this program that they give to everyone else? Or do they want to know that you're individualizing what they do? You have good clinical analysis skills. You can change things on the fly. You can provide a good treatment. I've also heard BCBAs say in the past, like, I make the treatment plan goals. Why should I ask the parents? I am the expert. Parents don't need to be a part of this. And that is something that, like, we shouldn't be training either. And I'll talk a little bit as to why clinical reasoning really does take into account our family's view and the whole child, whole family, whole client, whoever you're working with. So the autism field, we are billing medical insurance. If you're in the autism field, you are billing medical insurance. We really need to make sure that we're understanding medical necessity criteria. We need to be thinking as ourselves as medical practitioners. And BCBAs in training also need to gain an understanding of that individualized treatment, how to create plans that meet medical necessity criteria, and understand kind of the realm they're getting themselves into when they are providing treatment under medical insurance. And I found one, I've looked at many of articles recently on clinical reasoning across like a variety of fields. And I did find one definition that I thought actually really tied in very heavily to what we do. And this field, I can't remember the exact field I was looking at this point, but they had said practitioners' ability to choose the appropriate assessment, analyze the results, tailor an intervention, and evaluate the intervention's effectiveness, which I think is something that ties very closely into what we're doing all the time as behavior analysts. So we are doing an assessment. We then analyze our assessment data. We choose appropriate treatment plan goals. We determine our intervention and how we're going to teach those goals or what interventions we're going to do. We should be analyzing our data and effectiveness and then have it go through that whole cycle over and over again until we're ready to discharge that client or, we're moving on to something else. And I had to throw in precision teaching here. So very similar to what we do in the precision teaching field with describing, measuring, changing, and trying again. So you're thinking, I came to a supervision CEU. Why does this pertain to me? And I think that supervisors have the role to teach all of this. Not all of this is taught in your coursework. There's a lot of things on the task list that you're teaching in coursework. There's just a lot to cover, right? Coursework only covers a certain amount. Really, I think the best practitioners are coming out with both good coursework, but like really great supervision. And the role of the supervisor to go through all of these portions of the task list and not just teach you to answer it correctly on the test, because we can be good test takers. It doesn't mean that we're doing a great job applying that. The application goes hand in hand with understanding what you would say, your verbal behavior and your nonverbal behavior. Your verbal behavior being able to spit out all the terms on the task list, and your nonverbal behavior being able to implement all of those. And if you look at the task list, and you're teaching about it, this section ties in nicely to your assessment. The H section ties in nicely to choosing treatment plan goals. That also ties into determining your intervention, analyzing your data, and then putting them all together. I don't need to go through, everyone here should know the task list, but you get the point that the task list really is teaching you all these components, but it's your job as a supervisor to teach them how to apply everything. And it can be really overwhelming. So one thing that I think about a lot is like our students that we're supervising and people who are in school are learning a lot of information at once. Or I know, like, I don't know if anyone else here like teaches or has just a lot of students you supervise who are like, say that again. I don't know that definition. I can't do it. Like, or wait, I learned that, but I don't retain it because this week you're asking me about reinforcement and last week you're asking me about punishment and I don't know what you're talking about. And it's a lot to take in. And so then you get to behavior change procedures and you're like, how does this tie into all the assessments that I did? So it's your job to make sure that they're not this cat. And I'm not a cat person, by the way, just cats have the best memes. It really is. I'm a dog person. They don't make good dog memes. But it is that you're making sure that they don't look like this cat and they actually know what they're doing. The other thing that I'm going to talk about is that determining the correct intervention method isn't like an answer that I can just give you when you give me just one scenario. It really depends. It depends on a lot of different things. So this is an audience participation moment. What does it depend on? When I'm choosing an intervention, function of behavior, one thing it might depend on. What else? My online people can use the chat if you like. The learner's repertoire and skill set. Yeah. How the learner learns best. The appropriateness of the everything. Yes. Developmental appropriateness is huge. And sometimes I feel like a lot of people have joined the field. They don't have a lot of experience with children in general. And they're like, it's ready to teach them time. I'm like, they're 3. They don't need to learn time right now. So I think their age is huge. Someone had said the teaching context, history of trauma, motivation. Someone else just said yes, they like that. But there's a lot of things that we need to be thinking about when we are choosing interventions, and that goes into a lot of critical thinking skills. And none of it happens in isolation. So all of a sudden we're looking at all these different things to figure out what we should be doing and having a good foundational understanding of the science that we're working in. So as the supervisor, your goal really is to help develop those critical thinking skills in the process of assessment and intervention design to make sure that your supervisee understands all the pieces together and can make the right decision depending upon their client's need, which leads them then to individualized treatment decisions. And individualized treatment decisions are not these decisions, which I'm sure we know where this is coming from. And we're like, ooh, look at this little gap here. I think my treatment plan goal is that they will make eye contact as man 5 times in 30 minutes and I'm done. Which I'd take one look at this and I'm like, this learner probably needs a lot more than just 5 times in 30 minutes making a man with eye contact. I think we are missing so many more things here. And we don't know everything about their skill set just from looking at this grid. So that pick the hole and choose the goal is really not the area that we want to teach. We want to teach analysis, and a BCBA's ability to analyze all the things, right? The data, current contingencies, the context, which I'm going to emphasize a few times here because I don't think we pay attention to context enough, and making the treatment choice that is socially valid, which I think is another thing we probably don't look at as much as we should, has a very large impact on the success of their clients. And since medical professionals are incorporating this clinical reasoning into the training of their students, then that's our job to look at clinical reasoning as a supervisor. Good critical thinking, individualization of their treatment, and analytic skills should lead to better outcomes. So I don't want to say always does lead, because I can't say things will happen correct 100% of the time. There are a lot of contingencies at play, but it should lead to better outcomes. And I think a place where hopefully our field is going in the future is looking at client outcomes much more, being able to tell how successful you are as a clinician from your client outcomes, making sure you're paying attention to that. So if you can have these critical pieces in there, understand these critical components, you're going to have better client outcomes. And the importance of context. So how many times have people said or heard someone say, ethically, I cannot give you advice on the client I've never met? A lot, right? Because it's true. But, why do you say that? Anyone have a reason why you say that statement?
Because there's a but right after it. This is what I would do, or this is what I've done in the past, of what it sounds like.
Yeah, some people might actually answer the question and say, but I can give you some suggestions based on the sound of it. And yes, someone on the chat said, you don't want malpractice. Yes, very, very true. Keep yourself safe. ethics, we don't know everything that's happening. So the context of what's happening with that client changes everything. So someone can tell me something that might sound like some type of escape maintained behavior, but I don't know anything else about that client, so I can't make a decision. So when you're thinking about teaching someone how to make decisions, you should also say, like, I can't teach you all the things about what you do every circumstance in escape maintained behavior, because it's going to change based on the context. And there are a variety of factors that influence the correct intervention. Some of them might be things that everyone had said earlier, like learning history, previous treatment, potential reinforcers, the social validity, family preference, current skill repertoire, many, many things. And yes, from the audience, you don't have all the same info in the context of the person relaying a situation. You don't. And so I think even the person relaying the information might not have all the information they need, and they need to go do some more digging themselves. And context in ABA, this is one of my favorite articles where they actually did some research on comparing prescriptive versus contextualized ABA. Their prescriptive interventions were ones that were created by the behavior analyst alone. So the scenarios where the behavior analyst is coming in, saying exactly what's going to happen, and then just giving it to the family. And their contextualized interventions were ones that were created conjointly with the family. Their contextualized interventions included an assessment of the family context, so discussion of daily routines, things that were happening in their home to assist in the design of the BSP. And they looked at family preferences and interventions that fit with the current family routine. And we should not be surprised that the contextualized interventions had better results. So here it is in the research that we should be making decisions with the families. And it brought in the term context, which I think we should probably use more frequently to remind people that there's more that you need to be looking at when you're determining interventions. And I think this ties in really great with our ethics code. And I did not take like all the areas from the ethics code, because there's probably way more than I put up here that pertain to this. But if we're looking at some of them, selecting, designing, and implementing assessments, we need to make sure we're selecting the right ones, that we are using, that are, conceptually systematic, using our behavioral principles. We're implementing assessments with a focus on maximizing benefits, which means that we need to find the right assessment to use, and we don't use the same one every single time, because that's the one I learned. Making sure that we're using behavior change interventions that meet the needs of our clients, context and resources of the clients and stakeholders. And I'll talk a little bit about scope of competence, which seems to be like a bigger buzzword now, but it's one of my favorite words more recently. About scope of competence and our available resources when you're accepting clients and implementing interventions. So I took some examples from another field in looking at context and how they define context in clinical reasoning. And this one was looking at the physician factors, which is something that I don't think I had thought a ton about before I had looked at this model. And it's very, very true that we should be. So they were looking at clinical reasoning ability and taking into account the fact that, like, sometimes a doctor's working a 24-hour shift and they're really tired, and their decision might be different than it was another day. So their sleepiness, their burnout, their expertise, their cognitive load, which I think I can compare to, like, how much can someone really handle at any given time? And that happens the same with BCBAs as it does doctors. And then looking at, presentation of their patient, diagnostic suggestions, whether or not their patient has an English proficiency, and their factors with, like, just their appointment length. How long do they have to see the client before they're making a decision? And all of those have large impacts on that physician's clinical reasoning skills. So I tried to compare that to what happens with us in the field of ABA and BCBAs. And this is like I said earlier, I'm no expert in this. This is like me kind of throwing some ideas out there, and I'd be happy to hear anyone else's ideas. You can throw them in the chat, yell them out to what you think falls here. So it's not an extensive list, but BCBA's decision-making really does have a difference with their learning history. So what is your scope of competence? If you have not had a learning history that's extensive in a certain area, then most likely your decision is going to be very different from someone who has had extensive amount of time researching that or practicing at that, versus like I read an article on it last night, say about clinical reasoning, and now I'm the expert and I'm not. My decision is probably very different than someone else. Or just time in the field, experience, other competing contingencies. So whether or not there's competing contingencies at your work or at home, or that's all going to have an impact on what your decision and treatment is going to look like, or how you present to your client, your level of stress and burnout, and your self-awareness or perspective taking ability. I think that also has a large impact on the decisions that you're making. And then you have the family. So family's proficiency in ABA or their previous ABA experience, the family dynamics make a huge difference in the decision that you make. Their preferences, any other cognitive factors that are there, they too have competing contingencies, right? They have other kids, they have jobs, they have things they need to do. And those are all competing contingencies. So when you're like, oh, this intervention would be great, and I can't possibly do that because I have 4 other children and we both parents work, those are all competing contingencies there. There's socioeconomic status and available resources. And then your learner's history and the environment. So their skill set, available support, resources, preferences, all can play a factor. And I emphasized the BCBA one there. And then there's more. So if you're working in the insurance field, then you have the time allotted to you by insurance, therapy intensity, and assessment or treatment restrictions. So sometimes our funders like to make restrictions on what they think are, yeah, I appreciate the laughter there, what they think are the important goals or areas that you can work on, or how many hours they think you should be providing, or what assessment they think is the right one to use. So that also plays a role into your decision making. And one thing that I think we could probably do a better job at in the field, and I think like as someone who's going to be supervising someone who is going into the field, there should be a heavy emphasis on self-awareness and looking at the context there, being very aware of their own learning history, when their scope of competence stops, when they should ask for help, and being aware of all the things I've listed there, and teaching them to tact their own abilities, have a level of self-awareness, understand their scope of competence, and the ability to accept and seek out feedback. So I think accepting and seeking out feedback really starts in supervision. If you don't get a ton of feedback in supervision, you feel like you know it all, you can conquer the world, you graduate, you go out, and you're like, I don't need anything anyone tells me. I'm good here. I'm going to be the best BCBA the world has ever seen. And then maybe you still think you are for a little while, but that will be handed to you at some point. Or maybe not, depending about the amount of supervision you get when you're out. But I think if you create an environment in supervision with your supervisee or trainee, now they're called by the EACB, with your trainee, where they're looking for feedback and are okay when they get something wrong or don't know the answer, and you model that in supervision, they're going to have a much easier time when they're done and they're practicing on their own. And teaching that it's okay to not know anything. So I think that it's okay to not know everything has to be modeled by the supervisor. You have to look at something together and be like, ooh, you know what? I don't really know that either. Where should we look it up? Where can we find it? Who can we ask? Who's the expert in this? That behavior shows that like even you who is supervising them and maybe has many, many years, sometimes still needs to look things up, or it's okay that you don't have the answer because you're modeling that behavior for them. Then they feel like they don't need to have the answer. They learn how to gain those resources on their own. And someone from the chat, which I think is a very good point, learning to ask for help, and talking about it's hard because you choose between the quality of the help or be okay if the help is not to expectations. So I think there too, like know who to reach out to for help and teach them to like figure out who the right resources are. Obviously, if you start reaching out to people for help and they can't help you, or they're not helpful, that punishes that behavior and you stop asking. Or when someone reaches out for help and at that point, like someone is a little rude about it or says like, you don't know that, that also punishes that behavior and they stop asking.
I think we talk a lot about like being a humble learner.
Yes, being yes.
And I mean, you could be in the field and work in a particular area, and maybe someone's been in the field longer, but they've worked in a completely different area. Or someone's a trainee versus a supervisor, but potentially the trainee has had more experience in that particular area, and be okay knowing that it's this 360 piece and not just like one-sided.
Yeah. And I'm sure that the computer could not hear you, so I will repeat that. No, it was great. The audience here was just talking about being a humble learner. And I think too, like the field is so big. So while 72% of us are practicing in autism, in that 72%, you could be with adults, you could be in the EI population, you could be doing just social skills, you could be doing adolescents, there's a variety of things. Or maybe I know people who just work in the feeding field or just work in severe problem behavior, and other people just work in skill acquisition or EI. Like I know we're very spoiled here at Bierman that we have cute little kiddos who don't engage in a lot of severe challenging behavior, right? So our team needs to know that if it's very severe challenging behavior, one, it's not in your wheelhouse, or two, you need to ask for help because you just haven't experienced it before. And I think that admitting that you don't know something, right? We teach that in terms of ethics is more ethical than not admitting you know it or don't know it, and then trying to perform a skill you're not competent in. So I've heard people say statements before of, I don't want them to know I don't know how to do this, or like, they're going to think I'm bad at my job if I ask for help. And that's exactly what you want to try to have not happen, because then you're going to get subpar performance, probably worse client outcomes, when really there's usually a team of people who are willing to help. And then if you're not in an environment where there are a team of people willing to help, you should probably look at leaving that environment.
Chrissy, a comment came in, and maybe you have a suggestion. If they don't have that environment or that person to ask, do you have any recommendations on who else they could find or ideas?
Yeah, that's a really great question. So, and I will also open that up to anyone here who wants to answer it. So if they don't have people that they can ask for help, do you have suggestions on how to find people? And I can answer first for me. I think like networking is a great way. So go to conferences, go to events like this one, do things that can help you find other people who are experts at it. And usually if they're talking to you, they're probably more than likely willing to help you. I also tell my students, like, keep my contact info. And if it's something that we talked about in class, like you could reach out to me at any point, like go back to old professors. There's a reason why they're doing it. They're in the field. They will more than likely help you at some other point if you need it. And then outside of there, I mean, you go to CEU events. Yes, someone else at local state chapters. Ask those people for their contact information if they're willing to like help you out at some point. I think those are good ways to do that. I also think if you had a good supervisor, hopefully you keep that rapport and relationship and they can keep helping you over time. Anyone else? I don't know if anyone has anything.
There's a lot of presenters that say, save my information.
Yes.
If you always have questions, let me know.
Yeah, presenters at the end will usually put up like their email and say,
Yeah.
feel free to contact me. And honestly, I love when people contact me after, because I'm like, someone actually listens. It's so great. I'm more than happy to talk to you about the chart. Yeah.
I think one thing in that too is I always let the family know, especially if they state that maybe they have a priority in a certain area, that, hey, I'm definitely going to address this. However, this is not necessarily my expertise, but I have someone that will be able to consult.
Yeah.
We'll make sure that we can collaborate to help this.
And I think I think they're like being honest with families and saying like, I'm going to have someone collaborate. Let me introduce them to you. Cause I know like, we've done that before and a family's like, who's this person with me? And then once they realize like, oh, we brought in an expert, they're very happy. Then no, like no family is going to be upset that you're collaborating with someone else that knows more than you do to work with their child. Like that's a plus, if anything. And another article I thought was interesting in terms of providing that support and that network opportunity for people is that some of the research has shown, and I think burnout is also a keyword lately, especially I'm going to say post-pandemic, even though COVID is still a thing, is that, you know, high levels of burnout can correlate with levels of social support. So this article had found that, you know, social support in the work environment and training supervision opportunities were key predictors of burnout. So people who had less social support, who like had a worse off supervision experience, experienced more symptoms of burnout than others did in this research. So I think not only are you as a supervisor working towards getting better client outcomes, you're also working to make sure that BCBAs in our field don't burn out early. And I think like one of the things when I talk to people typically is where they're like, I need to change. It's because of a lack of clinical support. And when you have a lack of clinical support, it kind of spirals usually. And so if you teach people how to seek out that clinical support, because not every company opportunity is going to allot for a ton of support. So if you teach people in supervision how to seek that out and how to gain networks outside of just their work environment that last over a long period of time, I think you're really helping them with the future of their career. And I think the last thing that anyone wants to see, especially me, is our field become a place with very high BCBA turnover, very unhappy BCBAs, like the burnout rates going up. And that just like wasn't a word when I became a BCBA many years ago. Like burnout wasn't something I thought of. I was super excited to be in the field. Obviously, clearly still super excited, but it just wasn't something I'd ever thought about. And so I think for me, it's a correlation between watered down supervision and support over the years as we grew so fast. And suddenly, like, this is where we're ending up. So I think as supervisors, we play a very big role in this. And providing that post-supervision support, so providing ongoing mentoring opportunities, ongoing training and development opportunities, giving continued case oversight with opportunities to get assistance when needed without repercussions. So opportunities to provide that support without any type of repercussion coming from it when people ask for it, and helping BCBAs build a network. And I think the last point here, creating a culture that solicits feedback. So start with your supervisees to understand that like feedback is a good thing. Come and ask for feedback. As a supervisor, ask for feedback about your supervision experience and model that behavior that way. So you're creating that culture ahead of time. Oh, and in the chat, they're also suggesting that all attendees should share their information with each other and network tonight. And then give practice opportunities. So now going back to thinking about how we teach that clinical reasoning. So shifting back there a little bit, ways that you can teach better reasoning skills are just doing a ton of practice activities. Flexibility depending upon the context, give an example of a behavior potential intervention, and then talk about all different ways that context can change that. So take that same example of a learner behavior and then give different examples of different things that might happen and look at how you can change your intervention. Also throwing in another PT term here, you're providing a minimal rational set. So a minimal rational set is a meaningful set of the smallest group of things, examples and non-examples of something to teach it. So they need to come in contact with enough examples and non-examples. This is what you should not do to understand how to make the correct choice. Has to be meaningful enough to give examples to demonstrate how your decision-making may vary depending upon all those varying features. And then, using open book type assignments. So model how to research, model how to gain information, do things like case studies where you research it together. So find a case study and say, okay, where would we go to gain this information? Dig into a topic together as if they would have to do when they're in the field. Teach them how to use their resources based on their presenting problem. None of us know the answer, exact treatment intervention to every behavior in every context. I look up stuff all the time. Like, we need to teach people how to better use their resources versus just relying on like, oh yeah, I learned about punishment. I can spit out that intervention because I learned it on my staff meds. It's not how it works. And then again, let's see how many times in one night I can say model asking for help and using your resources. And then I think I want to give like a couple of examples of things that I had been thinking about in terms of tools that we could give future BCBAs and current BCBAs in order to help them work through some problem solving or decision making. So we can give or create more checklists, flowcharts, decision-making tools that help you figure out what you should be doing. So this is an example of going through, we've done our assessment. Am I going to teach a skill or reduce a behavior? If I'm going to teach a skill, have I checked on the family's preference and social validity of that skill? This is a huge one. Oftentimes, I think we're picking skills or are taught to pick skills based on the fact that like it just came up in their assessment. So it's great. I'm going to teach them like greetings or 500 nouns. And one of them is like ostrich and alligator. Like, do they really need to know that? Like, is that what's really important to the family at this moment? So you've picked what you're going to teach. Have you looked at family preference? Have you looked at the environment? I think environment too, like, have you looked at whether they'll actually come in contact with that ever? Are we teaching something to teach it and then mark it off on our treatment plan goal or VB map and move on? Like, what does their actual environment look like? Have I looked at their current skill repertoire? Do they have the prerequisite or component skills to even do this? Do I need to teach other things in order to get here? And then your teaching strategy. And I think then once you figure out how you're going to teach it, think about how you can teach it and make it fun. What's your learner's preference? And then for reducing a behavior, looking at, again, family preference. Is this a behavior that actually needs to be reduced in their environment, or is something that is important to the family? Level of severity, and then looking at your interventions again. Do I have a functional replacement behavior? What's their current skill repertoire? What are our resources? And then teaching them, if you're looking at a functional replacement behavior, you need to go back and think about skill acquisition again and go through that whole cycle again. And then assessments too. So I don't know how many people have ever come in contact with Pat McGreevy, who Dr. Pat McGreevy is probably like one of my most favorite people ever. And he's very passionate about the correct assessment. And he will tell stories about the fact that he has seen, people pulling out a VB map with a 20-year-old, not what that assessment is meant for. And so I think teaching people about assessments, how to choose the right assessment, is really like the first step of what is key in effective treatment. So if you're going down an academic path, you might have, and again, this is not an extensive list, this is me just like brainstorming how we can teach people, but you might use the VB map at that point, because the VB map is tailored to preschool, 4-year-old academic paths, or enables, or we've aged out of the VB map or we're done with that, we might go to the peak. If we're looking at vocational or life skills, you have the AFLs, you have the essentials for living. For behavior reduction, do I need to do an FBA or do I need to do an FA? And doing an FA, there's lots of different types of FAs. I think I run into a lot of new BCBAs or supervisees who is like, yeah, I read the Iowata article. I'm ready to go. I can do an FA, break out the colored shirts and I'm good. Like, that's not the only thing you should be doing. And some of them are just more functional for other skills or environments. So teaching people how to choose the correct one. And then early emerging learners, they're going to be different than, your adult learners. They're going to need different assessments. So an early learner, you might use the VB map, you might use, I'm big into the joint attention literature. So the ESCS is like one of my favorites, but I think just having resources more readily available to help problem solve would help with people's future skill set. And then emphasizing the need for regular data analysis and database decision-making. So making sure that we're teaching in supervision proper visual analysis of the data, understanding how frequently you should be analyzing your data and making decisions. And then going a step further than that and looking at family data. We don't do a great job at this in the field. And this is something that I'm personally just starting to dabble in more formally. But looking at more formal quality of life measures, there are a few surveys out there that you can use that give you pretty good quality of life measures. But then if you aren't doing it more formally, just look at parent report and progress. Like, how happy are your parents with what we're doing? Do they see any of the skills that you're teaching when they're not with you? You know, how we made an impact on the whole family's life. And remember that the learner, again, another precision teaching thing thrown in there, the learner's never wrong. So if something's not working, it's not the learner's fault, it's not the family's fault, it's our fault. So teach that statement early on to start teaching problem solving skills to new BCBAs, to say, like, don't get frustrated at the kid or the family, like, this is on you. This is the job you chose, it's not working, you need to make the decision to change. And teach how to make changes, right? So if it's not working and it's not the learner's fault, what might be the problem? So teaching them how to figure out why. Is it the MO? Is it, you know, someone's error in implementation? Is it missing component skills, their environment? And just one example of ways that you could do that is do practice. So we use error analysis to try to figure out why errors are happening, have people actually write it down and get IOA with their supervisor to practice. And then over time, you should be able to do this without the use of the worksheet, but the worksheet is very helpful. And then you break it down and you work together to figure out all the reasons why something might not be working so that you can make a correct change. And then I will end with my take home. I hope everyone has this, is just when you're in supervision, really thinking about teaching the whole process, making sure that your supervisee trainee has the skill set to work themselves through this process correctly, can use all their task list items, and think about context at the same time. So all of these other things that are impact your decision-making, making sure that you can use those while you're going through your process of assessment to treatment. And then you as the supervisor are there to help your BCBA. And that is my spiel on clinical reasoning and supervision. And I know we have like 10 minutes where we can answer questions if anyone has them.
My first thought is that not just applying it to our children or the clients that are paying, but also for BCBAs to be able to apply it to our BTs, our RBTs,
Yeah.
our clinical director to BCBA, and in that process.
Yeah.
As well.
Yeah. I actually didn't put that part of the task list up when I was looking at this because I knew it would take way more than an hour to think about how to become a proper supervisor yourself. But absolutely. So if you couldn't hear online, it was talking about not only using this process or thought process for our clients, but also for people who we're supervising, because that is part of the task list, right? You have to learn how to supervise others. So in addition to learning how to provide treatment, you need to learn how to then have people implement that treatment and how to be a good supervisor. And I think of it, it's like the same thing, right? Like you're doing all the same things, while you're not using a VDMAP on like a BT. There are modes of assessing behavior. I personally love the PDC, but you are doing some type of assessment. You're figuring out why behaviors are happening or how you can make more behaviors that you want to see occur. Like you should be using all the same principles, and you have to learn how to apply all of that as a supervisor when you move into that position too. Yeah, I didn't get that far in making job aids for that, but we should. And in the chat, they also love the PDC. Yeah, I don't know if anyone in the chat has any questions. For those of you who are here from the East Coast, I appreciate you. I see that it's 9:51 p.m. I know how you feel in the morning. Oh yeah, I was on some 6 a.m. phone calls this morning.
All right.
It was hard. It was hard. All right. Well, if nobody online has any other questions, I appreciate people coming.
Thanks, Chrissy, and everyone will receive a copy of this presentation over the next few days, and thank you so much.